Hi there, my name is Shay Connor and I'm a gynecologic oncologist at Erlanger. Today I'm going to be talking about the new 2019 ASCCP guidelines for the management of abnormal pap smears. There's a lot of confusion out in the community about why exactly these new management guidelines were even created. The last updated guidelines were from 2012 and everyone seemed to think they worked just fine. There was an app you could download to your phone and quickly plug in a patient's information, and it gave you the next step in management, and it really worked great. The newer guidelines are much more complex. They seem a lot more convoluted. The app update is no longer as user-friendly, and so I think it's been really poorly adopted by the community physicians because it's much more difficult to understand. So the reason why we had to come up with new management guidelines is that we had 3 screening options available that weren't accounted for in the 2012 guidelines. We now have primary standalone HPV testing as an option for cervical cancer screening, cytology alone with a pap smear, and co-testing with cytology and HPV testing. And the 2012 guidelines did not incorporate all 3 of those options. So we really needed management options that were versatile enough to apply to any of these different scenarios. I will tell you that the most appropriate screening option in a high resource area like the United States is going to be incorporating some form of HPV testing, whether that's co-testing or primary standalone HPV testing, because that's really the best estimate of risk. Cervical cytology has been a wild success in preventing cervical cancer, especially preventing deaths from cervical cancer over the past 70 years. But really, as a screening test, it's not great. The sensitivity for high-grade dysplasia or cervical cancer with cytology alone is only about 50% with a single pap smear. So incorporating HPV testing is going to detect much more of your high-grade dysplasias and cervical cancers. So in 2019, these new ASCCP guidelines came out. It is a very lengthy document. It's a lot to go through. So get ready. We're going to go through just as much as we can in 30 minutes. I think it's best to focus on the primary changes from the 2012 guidelines. And the most important thing is this #1 bullet point, that the recommendations are based on risk, not results. And that's why the new management algorithms seem much more convoluted, because you've got to incorporate a patient's age, their prior screening test results, their current screening test results, any past treatment they've had. All of that goes into factoring into their risk of current or future CIN3+. And that's really what we're going to talk about today, is a patient's risk of CIN3 or greater, CIN3+, meaning their risk of developing high-grade cervical dysplasia or cervical cancer. And we know now from several years of data incorporating HPV testing that we can accurately predict that risk based on a series of prior test results. So colposcopy can be deferred for certain patients, and we did that some in the 2012 guidelines, but now we're really incorporating these deferred management strategies even more, because we have a more accurate estimation of a patient's risk moving forward. On the other hand, we know that when a patient's risk is relatively high, they can be expedited to treatment and avoid colposcopic biopsy. The reason this is important is that colposcopy is time-consuming. It's a cost, no, not an extreme cost, but it is some cost for the patient. And it's extremely anxiety-provoking. And often women will opt for immediate treatment rather than colposcopy followed by treatment, because the anxiety of going in for multiple procedures is really just too much to bear. So anytime we can expedite treatment for those that it's appropriate for, that's going to be a good thing. Also, we clarify in the 2019 guidelines that excisional treatment is preferred over ablative treatment for CIN2 or 3 in high resource areas. Excision is always recommended for adenocarcinoma in situ. Essentially, the only time that you should still be doing ablative therapies with cryotherapy or laser is if you're in a resource poor area where that's your only option. Observation is preferred for CIN1 for all patients, regardless of age. And then they also clarified that histology reports should differentiate between CIN2 and 3. There was some push among pathologists in the last several years to use the same terminology we do for cytology, saying L-cil or H-cil, with all CIN2 to 3 being H-cil. But the truth is that there is definitely a stratified risk between CIN2 and 3, and especially for young patients. If you can identify something as CIN2 versus CIN3, you're going to manage that a lot differently. So the 2019 guidelines really push to make that distinction, but they also include management options for H-cil unspecified, basically when you can't tell the difference between CIN2 and 3. Also, all positive primary HPV screening tests, regardless of the genotype, should have additional reflex cytology. There was some debate about whether we should only do that for HPV 16 and 18, but really it should be for all HPV if you're using that as your primary screening method. We also change the follow-up surveillance guidelines a little bit. Continued surveillance with either HPV testing or co-testing at 3-year intervals is now recommended for at least 25 years after treatment of H-cil or greater. And that's a change from previously where we said that that patients could return to routine screening, which would be up to a 5-year interval for HPV testing after a certain time frame. Also, we increased the duration to 25 years from 20 years because we now know that a patient's risk of recurrent high-grade dysplasia remains elevated for a significantly long time. Also, surveillance with cytology alone is acceptable only if testing with HPV or co-testing is not feasible. Again, we talked about this earlier. In a high resource area, as a general rule, you should be using some form of HPV testing, whether it's co-testing or standalone testing in your cervical cancer screening, as well as your post-treatment surveillance. And in general, you should be using an HPV test that's FDA approved, and multiple new products are coming out that will be incorporated into that. So guiding principles for these 2019 guidelines, HPV-based testing is the basis for risk estimation, whether that's co-testing or primary HPV testing. Personalized risk-based management is possible if you know the current results and the past history. So it's looking at, the kind of the patient as a whole rather than one snapshot in time. The guidelines have to allow updates to incorporate new test methods, and that was really the problem with the 2012 guidelines, is that they didn't do that. And we have to expect that as HPV vaccination rates increase, the incidence of cervical dysplasia and HPV will decrease, and we have to have more sensitive and specific tests to account for that. And additionally, colposcopy practice should follow the detailed ASCCP guidelines, which are also elucidated in this document. Okay, so this is how the guidelines really stratify. It's based on 2 questions. What is the patient's immediate risk of CIN3+? or what is the 5-year risk. And so if the immediate risk of CIN3 plus is greater than 4%, which was identified in the 2012 guidelines as our acceptable threshold for intervention, then we move to these questions. We want to actually quantify the patient's risk and intervene appropriately. So if the risk is between 4 and 24%, then colposcopy is recommended. If the risk is greater than 60%, then expedited treatment, meaning you skip colposcopy and just go straight to treatment, is recommended. And then if it's somewhere in between, then either strategy is really acceptable depending on patient factors, age and future fertility desires, and what she would be most comfortable with. So it really gives you a lot more options. The other category is if the immediate risk of CIN3 plus is less than 4%, then you need to look at her long-term risk. Is the 5-year risk of CIN3 plus significant enough to intervene sooner rather than later? If the 5-year risk is very, very low, less than 0.15%, then she can really come back in 5 years. If it's greater than 0.55%, she returns in 1 year, and if it's somewhere in between, then you do come back in 3 years. Okay. So surveillance is an important point that we want to differentiate between surveillance and screening. Surveillance is follow-up testing at a shorter interval than routine screening. Routine screening with HPV standalone testing is 5 years. Surveillance means we're following up on abnormal test results, so we've got to decrease that interval. And it's important to note that if you're coming back in 5 years, that's HPV-based testing. Cytology alone is never recommended at 5-year intervals. The shortest you can do with cytology alone is every 3 years. The whole guiding principle is that we have equal management for equal risk rather than equal results. So this is the risk for CIN3 plus 5 years after a negative HPV-based screen in the general population, and that's why these patients can come back in 5 years. And again, in the 3-year group, this is the risk for CIN3 plus after negative cytology alone. So that's why they can come back in 3 years, similar to the cytology group. And then 1 year is recommended for minimal abnormalities based on the 2012 guidelines. So in the immediate risk of CIN3 plus group greater than 4%. This is again based on the 2012 guidelines that established this as an appropriate risk-benefit balance, and that's why we use this 4% cutoff. Some of the factors that go into determining this risk are the immediate test result you have. High-grade results like ASK-H, AGC, or HSIL are going to put you in the greater immediate risk category, whereas low-grade results, LSIL and ASCUS with positive HPV, might put you in an intermediate category. And then some extremely low-risk results for which colposcopy is not recommended is if you have negative cytology, but HPV positive, or these low-grade PAP abnormalities with negative HPV, because they're going to be an extremely low risk, less than 4%. It's also, again, how we incorporate prior test results matters. So low-grade abnormalities with a negative HPV test in the last 5 years reduces your risk down to about 2%. So that's why we recommend 1-year surveillance and not colposcopy in these groups, even though the same result with different prior screening results might give you a higher risk category. So looking at the colposcopy group, low-grade results with a recent negative HPV test would not be included in this. They would return in 1 year. All other low-grade results would go into the colposcopy treatment group. Another important point for expedited treatment is that this is only acceptable for non-pregnant patients aged 25 or older. Young women under 25 or pregnant women obviously should have colposcopy first. They should not be expedited to treatment. And this really just kind of clarifies what the risk is. So HPV is going to be the primary driving force for your risk. If you've got an HPV positive HSIL PAP, then you're going to have the greatest risk of high-grade cervical dysplasia, but the majority of those are going to be CIN2. And the important point there is that CIN2 is still very likely to regress in certain patients. So that's why we don't intervene in young women or pregnant women. In the expedited treatment group, these are patients who are at very high risk, greater than 60% of immediate CIN3 plus. And one important point is that we include the underscreened in this population. So if you don't have prior test results to incorporate, then they should go into the potential expedited treatment group. So an example, you have initial screening with an HPV positive ascus PAP. Her immediate risk of CIN3 plus is equal to 4.5%. So she gets triaged to colposcopy. At the colposcopy visit, the result is less than CIN2. So either you get a negative biopsy or a biopsy that's CIN1. We can now better quantify her 5-year risk of CIN3 plus at 2.9%. And so she gets triaged to a 1-year follow-up. At the first follow-up visit, she again has an ascus HPV positive PAP, but because we can incorporate this prior biopsy and her prior screening results, we can calculate her risk at 3.1%, which is lower than the initial 4.5%. And she gets to go to another 1-year follow-up instead of, again, to colposcopy. And this is all based on a complicated algorithm that, the app can do for you. You don't have to be able to calculate this yourself, of course. But the important point is that when we have multiple prior test results, we can stratify people more appropriately. And so then at her second follow-up surveillance visit, if she's got a negative PAP and negative HPV testing, then she can go back to 3-year surveillance. If she's got still has an HPV positive ascus PAP, then she gets triaged to colposcopy. But you can see how a certain percentage of people whose abnormalities would regress on their own get to avoid colposcopy by following this algorithm. I'm going to skip ahead a little bit in the interest of time to talk about management of some rare results. Atypical glandular cells is really a result that I would like all primary care physicians and providers, anyone who's doing pap smears, to be very, very aware that this is different from ascus. We used to call atypical glandular cells of undetermined significance agus, but that was really, really close to ascus. And those are two very, very different things. There is a much higher risk of a high-grade lesion or an invasive cancer with atypical glandular cells. I will tell you that the most common diagnosis, histologic diagnosis after an AGC PAP is actually CIN, not adenocarcinoma or adenocarcinoma in situ, but given the risk of those more aggressive cancers and precancerous conditions, you really have to be careful about managing these AGC PAPs aggressively. So essentially for most patients, if you get a result of atypical glandular cells that isn't specifically designated as endometrial cells, so just AGC on your Pap, then you're going to want to do a colposcopy with endometrial and endocervical sampling as well. The guidelines say that endometrial sampling is recommended for patients over 35, or if they're under 35 with risk factors for endometrial hyperplasia. But the truth is that's a large proportion of our population. Anyone who is at all overweight, anyone who has oligomenorrhea or irregular periods, anyone with PCOS or diabetes or insulin resistance, they're all going to be at risk for endometrial hyperplasia or cancer. So the majority of your patients are going to get colposcopy with ECC and endometrial sampling of some sort. And then follow-up surveillance after management. So if your initial cytology was AGC, not otherwise specified, and you do all this evaluation, the colposcopy with biopsy, ECC, and endometrial biopsy, and you find no CIN2 plus AIS or cancer, then they can be co-tested at 1 and 2 years, okay? If you have no glandular neoplasia, then you just manage per the guidelines for CIN. But importantly, if your initial cytology was AGC, favor neoplasia, or interpreted as AIS, and you do this full workup and it's negative, that's not enough. You can't stop there. You have to do a diagnostic excisional procedure. And what I will often see is patients diagnosed with an adenocarcinoma of the cervix who had a year or so ago a colpo and biopsy and ECC, and it was all negative. And so they were told, oh, well, you can follow up in a year. But the truth is, because of the skip lesions that can happen with glandular lesions, you might miss it. And so if you have a negative workup, you've still got to investigate a little further in these high-risk situations. Unsatisfactory cytology is another rare result that we need to talk about. It's important to note that if you have unsatisfactory cytology, you can't rely on your HPV test, because that's not the same thing as a negative primary HPV test. It might be that they don't have enough cellular tissue to actually interpret. And then endometrial cells are often reported. Pathology guidelines specify that they report the presence of benign endometrial cells in women over 40. In premenopausal asymptomatic women with benign endometrial cells on their Pap smear or endometrial stromal cells, no further evaluation is needed, but you really need to clarify and make sure that they're asymptomatic. You know, a woman who's having irregular periods is symptomatic and she needs additional evaluation. Postmenopausal women with benign endometrial cells on their Pap smear need an endometrial assessment because they're high risk for an endometrial cancer. So they should have an endometrial biopsy or DNC as appropriate. And then post-hysterectomy, if you find benign glandular cells, there's no need for further evaluation. I want to talk a little bit about some special populations. Women less than 25 years old are really a very special population that we're trying to decrease intervention for. There's some concern about excisional procedures and risk of future pregnancy implications. Some of the early studies that showed increased risk of preterm delivery and cervical incompetence with prior excisional procedures were likely flawed in that there were multiple confounding variables. Risk factors for cervical dysplasia were also risk factors for preterm delivery, such as smoking. But we do know that the majority of women under 25 will clear even high-grade cervical dysplasia on their own. And there is a non-negligible risk of cervical stenosis and potentially cervical incompetence, which can impact future fertility. So we'd like to minimize intervention in this group as much as possible. The HPV vaccine came out in 2006, and although our total vaccination rates are still pretty abysmal nationwide, we do predict that risk of cervical dysplasia will decrease as more and more people are vaccinated. So it's very likely that folks in this category will be infected with a non-HPV 16 or 18 strain. Those strains of HPV are much less virulent. They're much more likely to regress on their own. They're less likely to progress quickly, less likely to undergo or cause carcinogenesis. So they can be managed a little more conservatively. HPV is extremely prevalent, but cervical cancer is rare, and we have to keep that in mind. In women under 25, even high-grade lesions are very prevalent, but again, the majority of those will regress on their own. So they need to be followed closely, but don't necessarily need immediate excessive intervention. So essentially, when to do an excisional procedure on a patient under 25 with a high-grade or HCIL or ASCUS positive PAP. Essentially, they have to be non-pregnant. You would never do it on a pregnant lady. You can do it if you have a high-grade PAP that persists for 2 years, if the transformation zone is not fully visualized, or if you can't see the upper limit of all lesions. For initial treatment of high-grade lesions, this is preferred if CIN3 is specified on your histologic specimen. If CIN2 is specified, then observation is actually preferred, and that's why it's important that pathologists differentiate between the two, especially for this age group. Immunocompromised individuals, this includes patients with HIV, history of an organ transplant, stem cell transplant, lupus, inflammatory bowel disease, or rheumatologic conditions that have them on immunosuppressive therapies. These individuals have a different screening recommendations. We no longer, for the general population, recommend beginning pap smear screening based on initiation of sexual activity, but for this select group, we still do. Pap smear screening should begin within the first year of initiation of intercourse, and it should continue for life. There's some debate about whether we should stop screening at 65 years. For the general population at low risk, especially women in long-term relationships, stopping at 65 is probably okay, but not for immune-compromised individuals. We know that they remain at significantly elevated risk throughout their life, so that should be continued. And then when you first start screening, they should have a pap smear every 3 years for the first, every year for the first 3 years, and then every 3 years for life. Similar to the general population, we recommend cytology only at less than 30 years of age, and then co-testing after age 30. Recommendations for triage of abnormal pap smears is very similar to the general population. HPV positive ASCUS or worse generally gets referral to colposcopy. We're a little more aggressive with young women in this immunocompromised state. ASCUS with no HPV testing can repeat cytology in 6 to 12 months. And then get referred if repeat testing is ASCUS or higher. But in general, these should get reflex testing. And then LSIL or worse on your pap smear should get colposcopy regardless of the HPV result. After hysterectomy, as a general rule, and a lot of women in the population don't know this, but after a hysterectomy for benign indications with no history of CIN2+, we should not be continuing to do vaginal pap smears. But for some reason, it's still done widely in the community, and we often have to deal with these results. If a hysterectomy is performed for the treatment of cervical dysplasia, then you should have 3 consecutive annual HPV test results following the hysterectomy. And that can be cytology plus HPV co-testing or HPV standalone. And then long-term surveillance is recommended for anything CIN2 or above. And like we talked about at the beginning of the lecture, this means HPV-based testing every 3 years for 25 years. If a hysterectomy was performed with no prior CIN2 plus or they've completed their 25-year surveillance for CIN2 plus, then screening is not recommended. If vaginal screening is performed, then we have to deal with the results. And the guidelines did specifically address this because this is a common problem seen by GYN oncologists. Perhaps an unindicated test was performed, but now we've got to deal with the results. And basically, the guidelines do allow for dealing with that. Women over 65 who've had HPV testing, co-testing, or cytology, generally you manage those the same as you would in a woman under age 65. But national guidelines recommend discontinuing screening. I think that is still very controversial, and many GYN oncologists would say that you should base your screening on a woman's overall life expectancy. A healthy woman without medical comorbidities who could potentially live another 30 years should probably continue screening, and that is acceptable. Oftentimes we'll see L-cell results with a negative HPV or unsatisfactory cytology results in women due to vaginal atrophy. So you can, if you have unsatisfactory results or L-cell negative HPV, you can consider vaginal estrogen in order to improve your sample. One final word about HPV vaccination. We do not base our management guidelines on whether or not a patient was vaccinated for HPV. And that's because the guidelines are already very conservative for young women. And we're nowhere near the vaccination rates that we need for herd immunity. It's likely that one day when we get to adequate vaccination rates, these guidelines will be updated and will be a little more conservative. But until we get to that rate, we're now, at about a 25% vaccination rate. We need to be at 70 or above for herd immunity. So until we get there, we have to be a little bit more cautious in interpreting this. It's also important to note that the HPV vaccine can be therapeutic. There are specific trials looking at therapeutic vaccines, but even the routine Gardasil 9 series can help patients clear high-grade dysplasia. So if you have a woman that you're treating for dysplasia, it's always important to recommend that she get Gardasil. I will have patients come to me who were told, by their primary care doc, well, you don't need the HPV vaccine because you've already been exposed. We already know you have HPV, so it's not going to do any good. And that's not true. We have good data, studies that show clearance rates of high-grade cervical dysplasia are actually improved after vaccination. So I'd recommend that you give it to absolutely everyone you can. It's now approved for women well up into their 40s. Most effective, obviously, early on, but certainly any woman who's diagnosed with cervical dysplasia should be offered vaccination if she hasn't received it previously. Thank you very much. That ends my presentation.
Hi there. Thank you all for being here today. I've got a couple of questions already, so we'll get started. The first question is for immunocompromised individuals with no history of HPV or abnormal cytology, any follow-up needed on ASCUS HPV negative result? The person goes on to say, I have one who falls into this category and her transplant team requested I continue co-testing Q6 months. I think the transplant team is wrong in that situation. They likely don't understand the disease process. A negative HPV result gives you an exceedingly low risk of CIN3+, and generally no follow-up would be recommended for that at that short of a time frame, even for someone who's immunocompromised. Now, if they did have anything greater than ASCUS or an HPV positive result, then that would warrant closer follow-up. But 6 months is not necessary in this case. The next question I think is a really important one because this is something I hear a lot. It says, what are the recommendations for a woman who starts penetrative sex in early to mid puberty or has been sexually abused as a child or teenager? And that's a really excellent question. It's important to note that the screening recommendations do not change based on the age at which sexual intercourse was initiated, except for people living with HIV or who are immune compromised. I know that's hard for a lot of us to come to terms with, but the truth is HPV is spread via skin-to-skin contact. It does not require penetrative intercourse, and many teens and young adolescents are engaged in skin-to-skin contact of a sexual nature at some point, and they all contract HPV and they all clear it. And the recommendations stand regardless, okay? Next question, recommendations for 60-year-old female with dementia, with behavioral disturbance, nearly requiring full care by another adult member of the family, with no recent cervical cancer screening in the last 20 years. Should I screen this individual or not? Yeah, I would suspect not in light of low life expectancy. So that's a really great point, that the screening recommendations between age 21 and 65 are generally in people with an average life expectancy for their age. In this case, it might not make much sense. Now, it's unfortunate that this particular patient doesn't have any up-to-date screening within the last 20 years. But I think that's a risk-benefit discussion you have with the patient's family. If obtaining a pap smear would mean taking her to the operating room for an exam under anesthesia, and she's got a life expectancy less than 5 years anyway, then that may not be worth it. On the other hand, if you've got a super healthy 65-year-old who has a life expectancy of 20 plus more years, you may want to consider continuing cervical cancer screening. In my healthy 65-year-olds, that's what I do. You know, the guidelines are made based on population-based data and the average life expectancy. But I see a lot of very healthy 65-year-olds who could potentially live another 20 or 30 years. And many of them are widows or divorced and will be exposed to HPV for the first time since their early 20s. We also know that there is just a kind of bimodal distribution of HPV expression based on age that does not necessarily mean there was a new infection. But these postmenopausal women can sometimes have a resurgence of their old HPV. So yes, you know, these guidelines are just guidelines. They're not hard and fast rules. You base everything off of your particular patient's life expectancy and desires. Even though PAP is for cervical screening, does a recommendation for stopping at 65 bother you as far as occasional finding of endometrial lesions in asymptomatic patient? I think, yeah, I did just address that a little bit, that, you know, I think your cervical cancer screening should continue if you have a reasonable life expectancy. You do occasionally find endometrial lesions on pap smears, if you see glandular tissue in a postmenopausal woman. The truth is the pap smear is not a good screening test for that at all, but a good review of symptoms and an annual pelvic exam is. So I highly recommend that women continue an annual well woman exam, because there's a lot more that goes into that well woman visit than just the pap smear. Hope that helps some. Let's see if we get any more questions here. I will say the one final question that I get asked a lot is, what is the optimal screening? And it doesn't help that multiple societies have issued different guidelines. The American Cancer Society now endorses HPV standalone screening every 5 years, starting at age 25. ACOG and SGO have not endorsed that as of yet. My personal bias is that I will follow SGO until they change, and they still recommend screening with cytology every 3 years from age 21 to 30, and co-testing every 5 years after that. And I think that that is very reasonable and supported by the data. The truth is, the American Cancer Society recommendations are also based on really good data as well. And that HPV test at 25 will actually probably prevent more cancers than cytology alone in that age group. And that 25 to 30 age group is a very rare group to get cervical cancer, but the jump between 21 to 24 and 25 to 30 is significant enough that I think they warrant a little more aggressive surveillance. Multiple societies have come out with statements elucidating the evidence. And I think the most important thing is that you can be comfortable with the screening guidelines, whichever society you choose to follow, whether you're SGO and ASCP and ACOG or the American Cancer Society. They're both probably pretty darn close to equivalent. But you should be incorporating some form of HPV testing into your routine cervical cancer screening, because that's how we're really going to prevent cancer and CIN3+. I think if that's all we've got, thank you everyone for being here today, and it was a pleasure to do this.